All right, so while we're waiting for, are you reaching out to Mo?
Yeah, I already texted both of them, yeah.
Yeah, perfect. All right, so while we're waiting for them, let's pretend we didn't have this two-dimensional blue halo, and let's kind of go around marking the margin. So back in the day, it was not uncommon for general dentists and prosthodontists to go to the lab after the lab technician had kind of poured up the model and then create what's called a ditch die, essentially an analog version of what we see here, and then the dentist would take a red pencil and mark the margin. And that's really what we're aiming to do here, is to have the doctor's help. So I like the flow from the distal buccal. So let's start in the bottom left corner of where, keep this screenshot where it is. In the bottom left corner where you had started, let's go from there to the right. Yep. So I really like all of the dots all the way until right about there.
Here?
Do you see how the pitch changes a little bit? There's 3 dots that form, yeah, right there. So kind of straighten those out a little bit. Yep. Perfect. Now there is a root undulation there, which is not atypical for molars, especially on the buccal, to have that root concavity. So that flow that you see is good, but it flows gently. There's no sharp changes until you get right. Let's see if I can take over now. Yeah. So right about here. Now I'm using that two-dimensional representation. It's much more illustrative now. So this is what I want to get Mo to tell us, is why does it not look like this all the time? I can see the arrow in the blue halo. The arrow is where my cursor is, so that's really not that important. What's important is where the green dot is, and I want it to be right about there, because that's where the zirconia is going to start the restoration. If I went too far in this direction, we're going to have an underhang, for lack of a better term. And if we go too far this way, we're going to have an overhang. And this placement is everything when it comes to clinical adaptation of the margin to the crown. So this, again, this exercise that we're doing is everything to me and why we're doing this with you. So I like where it's at. I like where that one's at. I like where that one's at. That looks good. That looks good. Here, I'd probably bring this one down a little bit. Now we have a rather sharp change in the pitch of these green dots. So to me, there's something we need to modify here, because teeth don't have sharp changes like that. So what I would do is probably come down like so, but I actually think this one is correct. So I'm going to come back to this one, and I think this one's a little too far down. So I'm going to bring this one over here.
Yep.
Right about there. So now I like how this flows a little bit better. This one can come down a little bit. This one come down a little bit. So it's here when that two-dimensional representation, I'm losing orientation. That's what I'm hoping Mo can help us with. But if I'm using this, the three-dimensional rendering, can you rotate this to the upper left? So kind of clicking, yeah, and then rotate up. Yeah, all right, so that's good there. Now we can add dots, correct?
Yeah. Do you want me to add one?
Yeah, let's add one right here. Yep, perfect. So in this area, and it's not atypical to lose accuracy of the margin interproximally, it's up to us doctors to do a good job retracting. It's easy to retract on the buccal and lingual, harder on the interproximal, in great part because a lot of times the margins are dropped in those areas. So this one's a little tricky. Let's add one more dot right here. Beautiful. Right there. See, now the two-dimensional image to me makes a lot of sense. That green dot is right at the beginning of the pitch change.
Yeah. That's interesting.
Right there. All right. So now in this area here, we need to make a decision. Is that the root changing pitch, or is that a distortion of the impression? And I don't have the answer here. This is where the doctor who did the case can sometimes provide some insight on what's going on here. But let's turn this whole thing to the left. Just a little bit. Right there. Yep. So I'm going to move the green dots a little bit. So for us doctors listening to this recording right now, it's helpful to take a flame shape or torpedo burr and smooth out these edges for the lab. I don't know, where I was taught, I was always kind of impressed upon that you really don't want to touch the axial surface of the roots or the axial surface of the crowns. Fast forward to today, there's no reason we can't do that. Periodontists reshape root surfaces all the time. Essentially, that's what we're doing here. So when we're done, before we take the impression, it's a really good idea to go around after you pack maybe that first cord and just make sure that there's no overhangs like this. These overhangs can happen for a multitude of different reasons, anatomical variations being probably the most likely scenario. But we want to make sure that we're creating a nice smooth surface for Vika to be able to follow. So here we don't really have that. So the lab basically has to just split the difference. So Vika, that's about where I'd put that. Maybe you come out just a little bit. To me, this is a distortion. So I would probably just say, crown, you're going to end right there. You don't want to overdo it. It's better to have it underdone, and then the dentist can smooth that out upon delivery. And then we come over here. Yeah, so an area like this probably needs more dots. We don't have to do that now. Again, this crown was already delivered. We're doing this more for illustrative purposes for the doctors. So essentially we go around the margins like that. And what I'd like you to do is to spend, a half hour with the doctors learning how they want their crowns designed. This is going to help them immensely with their preparations. It's helped me immensely just in the few cases that we've done together. And then over time, you letting us know as a group of doctors what you need to make this much easier. Now, if we do a really good job, the artificial intelligence and the software should probably pick up the margin really well.
Yeah, which is what happened in this case.
Yeah, so
I've never had that happen before with any other crown where it just picked it up right away.
Yeah. So the more that happens, the more we as the doctors need to replicate what that did. So I'm going to talk to Dr. Libby and see what he did to to get this kind of retraction. It's not always going to be the case. Patient to patients have different levels of retraction. Sometimes the doctors go deeper for periodontal stability reasons. When we go deeper, we have to retract more, or it's harder to get these nice visible margins. But this constant conversation that we have with the doctors is going to be helpful. So as you start to notice trends, is there certain doctors where the margins are easier? Just kind of make notes, and then you and I sit down and I'll do a good job of kind of passing those messages along so that all of the doctors become maximally efficient at getting you really good margins. That sound good?
Yep.
All right. So once the margin is there, what's the next step? So if you want to kind of walk through what you do so you're happy with that.
Yep. So we just go next, and then it's just gonna do like the insertion direction, which I usually just set the current view as the insertion axis, which I don't know, I think that looks okay.
So when you're doing insertion axis selection, what you want to do is you want to maximize the visible tooth structure, which is what you just did right there. What I mean by that is you're looking down on the preparation, and you want to see as much of the tooth as you can, which you did here. So you don't want to have any undercuts. If you have undercuts, you want to minimize the undercuts. It's okay to have them. I say it's okay to have them. It's not the end of the world to have them, but you want, when you select the insertion path, you want to minimize it. The other thing you're accounting for are the contacts of the adjacent teeth. So you want to make sure that you equal, and you're in a good spot right here, so I don't want to say one way or the other. You don't want to see more of the contact surface of an adjacent tooth compared to the one next door. And I would say maybe rotate this to the left a little bit so you can see a little more of the mesial surface of, yep, perfect. And maybe down a little bit so you can see more of the prep. To the right a little bit. What is that green dot in the middle? Is that the insertion axis?
Mm-hmm.
Did it just reorient itself?
Yeah,
Yeah.
I just put it back to the middle.
Gotcha. So what we're doing here is we're making sure that we maximize the contact points on the adjacent teeth. So this insertion access determination is an important part of the process. So number one, you want to see as much of the prep as you can, which we can here, but then you also want to make sure that you see the equal amounts of the adjacent contacts on the adjacent teeth. Sound good?
Yep.
All right. So go ahead to next.
So I usually adjust the margin line to 0.5.
So the margin line, so we're on the cement gap on the left?
Yep. Mm-hmm. So the cement gap is already at 0.5, which is what we've been doing.
All right, let's keep this right here. I want to have a quick conversation with the docs on this. So cement gap is the digital term for what we used to call dye spacer. Dye spacer was a paint or a shellac that we used to put on the models, on the stone models during this step of the process. And that dye spacer or paint had a certain thickness to it that would account for the future cement gap. But now we can do it digitally. We can dial it in digitally. The cement gap doesn't go all the way to the margin. And the reason for that is if you had a gap all the way to the margin, then you would have a gap in the crown. The crown would actually fall down. So there's a zone of very little cement gap around the margin, a certain distance from the margin. And you can see it, I think it's that teal color. That's the area where the cement gap will not be present. So the 0.5 is everywhere except for that teal zone. You can control that through the distance toggle there on the bottom left from margin, and you have it set at 0.5 millimeters. So we're going to keep it at this. So we have 0.05 cement gap thickness. We may actually bring that down depending upon how the crowns are fitting. And that zone of the intaglio surface is inset by 0.5 millimeters from the margin. We may change that over time. So these factors, although Vika, you were taught to have them set at these, I think there's the opportunity for us to modify these over time, depending upon how they're fitting, depending upon the materials we're choosing, depending upon the prep designs of the doctors. So these are not necessarily going to stay here. With that said, I'm happy where they are right now. Now, 0.05 millimeters is 50 microns. And in my experience, this is where most labs start. I have found the crowns to be rather sloppy at 50 microns. In other words, we seat them down and they kind of float on the prep. We can bring it down to 30 microns, which would be 0.03 millimeters. I worked with a lab where I had it down to 0.25, which is 25 microns. But the doctors are getting pretty good about putting retentive grooves into their crowns, which helps the retention. So let's keep it here, but over time we might find that the cement gap thickness is actually less. If the doctor doesn't put retention grooves in, I would probably say you're more likely to want to decrease that cement gap thickness. Now, the downside to overdoing the cement gap thickness reduction is the crowns don't fit and the doctors have to adjust them chair side, which isn't the end of the world, but it's time and frustration. With that said, they tend to fit better. So there's a happy medium somewhere in there that when we put the crowns on the preps, that they fit with a high degree of positive seating. All right, so thank you for letting me talk a little bit about this particular part of the process, because it's an important part of it. All right, so once you're happy there, what's the next step?
I think it's just going to generate the crown for us. Yeah. So that's kind of the...
All right, so it uses artificial intelligence to find an approximation of the tooth.
Yep.
And then you go in and you modify cusp tips, grooves, strength of contact points, so on and so forth. So this is where, I hope the doctors aren't too picky, but I also hope they're picky.
Yeah.
One of the things I get frustrated about with Glidewell in particular is they'll often not make it look like a tooth. They'll just kind of squish it until it fits occlusally, and then they mill it and send it off. We need to make teeth look like teeth. Form follows function, function follows form. So we want to make sure that the tooth looks good, and I think in this particular instance it looks like it's heading in the right direction. But don't rely on the artificial intelligence to give you the ideal tooth. You want to use contralateral teeth, adjacent teeth to kind of guide you. But we also want to have some sort of understanding of occlusion. And looking at this patient here, you can see it's not a wear patient. He doesn't grind his teeth, at least not to any big degree. If there was wear on the adjacent teeth, then you probably wouldn't want to have these steep cuspal inclines. So understanding occlusal wear is an important part of this process. I actually think those are pretty steep. I would probably take those lingual cusps and flatten them just a tad. So if you can just do that.
Yep. You have to go to the next step.
Perfect. Yep. And Vika, you and I had talked a lot about this view here, the buccal corridor view, where we want to make sure that the buccal and lingual or palatal aspects of the teeth follow in their contours and pitches to the adjacent teeth. And we're pretty close here. But see how it's called the height of contour. So go ahead back, you were right there. Bring it up a little bit. And then to the right a tad. Right there. Height of contour is the aspect of the tooth that is the widest in a buccolingual dimension. Right now the height of contour is rather cervical. So you want to maybe bring that bump on the cervical and kind of bring it up a little bit, or flatten it. Right there. Do you see the bump down at the bottom right? I'm going to grab the cursor here for a second. So right in this area, if you can flatten that, and then get some more roundness up here, following this angle right here. So we call this matching the buccal corridor.
So, minimum thickness here.
All right, so this is good for us to have this discussion. So to the doctors listening, minimal thickness is essentially the thickness requirements for this material are starting to get violated. So she's going to have to make a decision. Does she create a reduction coping, which is really not, I don't think, necessary here, or add more material? So here, rather than taking away, you can start adding. There you go. That's looking better. Now go ahead and smooth that out, because I can tell there's some bumps. Good. And now let's look from that buccal corridor view one more time. There you go. So that's better. Yeah, I mean, there's a couple things I would change there, but for all intents and purposes, we're in the right direction. But you're limited by the preparation. So the doctors need to know how to prep a tooth so that the material demands of the future crown are satisfied. Now, here's a question for you, Vika. How does this software know what you're going to be milling right now?
Does it know what I'm going to be doing?
Yeah, so the minimum thickness of the materials change, or they should differ from different milled materials. So for this software to tell you we're starting to get too thin, I feel like it should know what material we're going to be milling.
Yeah. So when you start the whole, design process, you have to choose the material.
Okay. So it does know.
Yeah.
Yep. Perfect. All right. Another part of the conversation that you and I have had is the root undulations. Here is not a great example, but from a periodontal health perspective, making sure that we're following the contours of the root surface. So there's something called barreling, where, let's just say there was a root undulation here. You would take that that buccal groove, and you might extend it all the way down to the cervical margin. So I'm putting this here. I know you know this, but I'd like the doctors to create that eye of when there is root undulations to make sure that they reduce enough on the preparation so that you can create that crown undulation to match the root undulation. Several of the doctors are aware of this clinical feature, and it's something that we should master over time. This tooth doesn't have it, so it's kind of hard to describe, but root concavities and furcations are challenging when it comes to crown design. So the doctor would really kind of guide you on what they like based on buccal corridors, occlusal groove anatomy, cuspal inclines, cuspal design. Once you're happy, then you go to contact strength. And our goal is to really have good contact strengths all the time. So the other question I want to ask Mo, and you and I have talked to him about this, but I don't think he answered the question, is the contact strength. Can you bring up or show me the contact, the interproximal intersection? So I think you can get rid of the stone model and it just shows the crown. There we go. So the bottom right green area, we definitely want to get rid of all of that. Yeah, I'm surprised that's there. Was there something on the adjacent tooth that was sticking out?
Not sure. Check.
I think it's the gingiva that's just sitting close to it and is giving us that. So I'm going to show you if I can take over right here.
Yep.
Yeah, so this area right here is there because the gingiva was close to that part of the crown. So I would ignore that, but just know when you're looking at this, know what that's getting at.
Okay.
All right, and then if you look at this contact point again, so if you can move this up, yep. So you and I were talking about where this needs to be in relation to the heat map up above. So you have the intersection on the left and clearance on the right in that white box up above. I think when Mo had first talked about this, he's like, the blues, you want to be in the happy zone. He uses that analogy of being in the Caribbean. We should be a little bit more exact in using analogies like that. I know he's trying to simplify it, but there needs to be some sort of understanding of the color on that heat map that we're looking for that translates to the strength of the contact when we deliver the crown. So I think this color here is probably where we're going to start. But let's say the doctors are telling you that the contacts are light. You'd actually want to increase the amount of green in the contact area.
Yep.
All right. If the contacts are too tight, then we want to increase the blue or the deep blue. My guess is that it's probably going to be somewhere around where this is now. I asked Dr. Libby to send you his insight on the crowns, and I think what we're going to do is create a checklist of different clinical outcomes so that you can see every single time how are the contact points, were they weak, strong, perfect. Glidewell has one of those cards, and I think we're just going to copy that. And every crown that you do, make sure you get one of those back so that you can modify and get better each and every time using this software. Contact point location. This is a perfect location, but do know that the contact point location on each tooth varies. And that's part of learning dental anatomy, is where is that contact point supposed to be. The bulk of what you're going to be doing is molars and premolars. In general, it's not halfway down. It's halfway between the halfway point and the marginal ridge, which is right where you have it here. So the software is good, but man, you and I have done a few of these where the software, the artificial intelligence was not spot on. So you need to know where these things should be and not rely on the automatic software. All right, so make a note to learn the contact point locations for all of the teeth in the mouth as a long-term goal. I don't love the root, or not the root, but the undulation of the crown right here. To me, this would be a food trap. I don't think there's a root surface undulation here. Now, if the root did have this kind of anatomy to it, then sure, keep it here. But this would be dangerous for food impaction over time if there's no root undulation there. So I would kind of smooth this whole thing out. You don't have to do it now, but I'm just making the comments as you're starting to learn how to optimize the teeth. That would be something to keep in mind. And then the last thing is the occlusion. So go ahead and spin this down so that we're looking at the occlusal surface. In general, we don't want to have contact points on the inclines. We want them on cusp tips and in the flat areas or the grooves. So I would kind of thin out any area where you're seeing the inclines, contacts on the inclines. Now, for the doctors listening, Vika can increase the grooviness. Vika, can you make a, right in this area right here, can you strengthen these grooves to make them look more defined? Just so the doctors can see what kind of control you have. So I think this is pretty cool.
And now it's add more points here. I add the material.
Yeah, I think if you go to a fine dot with medium strength and then accentuate the grooves that are already there, I think that'll drive the point home. There you go. So you don't have to put a groove there because that's a ridge, but make the existing grooves deeper.
Are you saying to remove the material, not add?
Correct. So you see that middle groove that I'm going to take over for just a second. This groove right here, can you make that more pronounced or defined?
Yep.
I wouldn't necessarily do that. I want to show the doctors that are watching this what your capabilities are. There you go. Yeah. I feel like when you and I had done this, it was more pronounced. I mean, I see what you're doing, and it is making some changes, and I actually think they're favorable changes. Go to strength and turn up the strength, because I think that was the parameter. So turn it to the right. Yeah, so that's actually softening the grooves, which for some teeth might actually be the right thing.
Do you think it's softening it? I mean, I can definitely see a difference here.
Yeah, it's making it deeper, but it's softening it at the same time. We had found a combination of these two so that it was making a very deep groove. The kind of grooves that we fill in kids with sealant material. Honestly, I think it's fine. I just wanted to make the point that you can make them more groovy. Brush size all the way down. Smooth, flatten, add, remove.
Maybe.
We'll play around with it more. I think there's a combination here that we had done that had made, to me, the brush is still too big. Maybe bring the strength all the way to the right, and let's see what happens with that. No, to the right, all the way to the other side.
Okay.
Yeah, now try it. Yeah, that's what. So that's what I was talking about. Much more detailed anatomy.
Oh.
Again, some teeth are going to have this, others aren't. So you have to look at the adjacent teeth to gain some understanding. Are you trying to get these deeper grooves, or are they more shallow grooves? Are they wide? Are they narrow? Yeah. So the strength is essentially the depth at which each swipe that you're doing is creating in the crown, and then the brush on the brush is the width of that.
Yep.
Yeah. All right. So that's good there, and that's pretty much it. And then you go to mill. I think this is good for the video, so I'm going to go ahead and stop it. But I think now the doctors should have a good understanding of what you're doing on the other side so that they can maximize their prep designs accordingly.